Howdy, folks. It is the 30th of August, 2024, and this is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of rheumnow.com. This week, so much news, so much info. Let's just tease it by saying we've got tips. We've got tips on steroid management, tips on macrophage activation syndrome and what to consider, tips on myositis testing. Let's start with something you know, and now you can add to what you know. You know that the way to reduce the risk of uveitis, either its onset or recurrence in patients with spondyloarthritis, is to use, certain drugs, specifically the TNF inhibitors that are antibody based, right? More so with adalimumab and infliximab than with etanercept. Well, there's been hint that the use of IL-17 inhibitors are also effective in this regard. And then this week we have the publication of the bimekizumab data, bimekizumab, the dual IL-17 A and F drug that's been approved for psoriasis, not yet approved for psoriatic arthritis or spondylitis. And they presented the results of the B-Mobile trials in axial spondyloarthritis, B-Mobile 1 and B-Mobile 2. Large number of patients, 350 patients, and looked at the occurrence of new uveitis events. You couldn't have uveitis going into trial. And yes, if you were on bimekizumab, it was 0.6%. If you were on placebo, it was almost 5%. The actual rates were 1.8 versus 15.4 per 100 patient years. And even if you had had a prior history of uveitis and took either placebo or bimekizumab, there was a significantly lower risk, event rates of 6 versus 70 per 100 patient years. So I guess the point there is that if you have a prior history of uveitis and you take a drug that won't protect you, the event rate is 70% of people in 1 year are going to get uveitis, whereas if you did a protective drug like bimekizumab, it's much less, right? It's now down to 6 per 100. I think that's very useful information. I don't know if you've ever had a problem with your patients and Myositis jirovecii or PJP infections. I've had a few in my career, and we've talked about PJP in the past. So what do we need to know about this? A recent retrospective review of 58 patients with lupus who had PJP infections was somewhat instructive. First, 39% of those people died. Not good, right? This is an infection you don't want to get. And part of that might be that there's often a delay in the diagnosis. It's often not considered early. And it's also a bad infection. It's an opportunistic bug. These events were more common in patients with diabetes than those who required mechanical ventilation, but the mechanical ventilation means that they were sick enough that they were had a higher risk of dying. Turns out predictive factors for PJP related mortality was having hyperglycemia, diabetes, low complement levels, and thrombocytopenia. To me, that sounds like diabetes plus active lupus. And we've talked about PJP here in the past. Risk factors for PJP include lymphopenia, high-dose steroids, right? We see more of this in certain conditions. And then the other one that you should remember is rituximab. Not really with traditional DMARDs or other biologics other than rituximab. So again, I think this is an instructive piece. This week, I was in a discussion talking about how you should stop steroids in someone who's on steroids. And I was trying to make the point and back it up that, if you're on steroids for less than 4 weeks, you should just stop steroids. No need to taper. So I did a Twitter poll, and an overnight Twitter poll ran for 18 hours. I had 133 responses. The question was, how long must you be on prednisone 40 milligrams a day before you must slowly wean the prednisone versus stop them abruptly? And your answers, not maybe you, but all your colleagues, were all over the map. The most common answer was 2 weeks by 50%, 3 weeks by 19%, 4 weeks by 26%, and 5% said 6 weeks. So So what's the real answer? Well, it turns out it's hard to know, it's hard to find the real answer. And I did spend a fair amount of time looking for this, and I published this on Room Now and also on Twitter this week, that the British Endocrine Society and the Endocrine Society came up with a consensus guideline that was published about 4 months ago about the avoidance of adrenal insufficiency. And in there, they make their statement that says, number one, to cause adrenal insufficiency, you need to be on steroids at any dose almost, or a dose that suppresses your endogenous steroid, that would be 5 milligrams or more of prednisone per day, for at least 3 and probably 4 weeks or more before you're at risk for adrenal insufficiency. Okay, so that should guide you as far as to when you can abruptly stop steroids and just move on and not play games with steroid tapering. That means steroids at any dose of prednisone greater than 5 for more than 3 weeks might need tapering, but less than 3 or 4 weeks, nope, just stop them and move on. And I don't know about you, but I've had lots and lots of patients who potentially put themselves at risk by how they abruptly stop steroids. And I got to tell you, Addisonian crisis and real adrenal insufficiency with abruptly stopping steroids is incredibly rare, even in people on chronic steroids. But nonetheless, this is the guideline that's out there from the endocrine societies as to how we should behave. A lot more on steroids this week we published. The RISE registry did a study looking at patients who were prescribed prednisone by their primary care doctors before the patient was seen by a rheumatologist. Turns out that if prednisone was prescribed before it got to rheumatology care, that those patients were more likely to end up on chronic steroids. This is a study of 1,700 RA patients, 700 treated with glucocorticoids, and then again, showed that while many of them were on it for like a mean of 157 days, the ones who got steroids before they got to the rheumatologist were going to be on it much longer. Suggesting that indiscriminate use by people who don't really know or manage chronic steroids well should be discouraged. And this gets into the issue about what's the role of the rheumatologist in educating primary care. And we want to, but it's not an easy thing to do, and there are many people who've tried to get involved in primary care education, just about rheumatology in general, steroids specifically. It is a difficult undertaking, requires, I think, a much deeper partnership between the societies, the ACR, the AAFP, ACP, etc. There was another report, let me scroll down, about which drugs are better at steroid sparing. We've reported in the past about with all these great new drugs, biologics, targeted synthetics, theoretically, that they're so good that we should be able to wean our patients off steroids. Turns out we don't. So the fact that these new drugs, expensive drugs, aren't steroid sparing is a little disconcerting, because it should be one great benefit to better therapy is that you can get off of steroids. Well, in this analysis of, where is that now? 700 plus RA patients, they compared patients starting who were going on a JAK inhibitor versus biologic DMARDs. Most of them were biologic DMARDs. And it turns out that JAKs were a little better than biologic DMARDs. We're being more able to rapidly reduce glucocorticoids in the first 6 months, and a 60% higher odds of being totally off of steroids within 1 year. I think that was encouraging, but the actual numbers are still not great. Greater than 50%, around 50% with JAK inhibitors, around 40% with biologic DMARDs. Still, a lot of people are on these drugs. It's something that we need to work at. So let's move on and talk about macrophage activation syndrome. I don't usually put up anecdotal case reports because I don't know what we can learn from case reports, but I think it was in JAMA, there were 2 case reports of patients with refractory macrophage activation syndrome who had failed a number of therapies you would use, and that would include, calcineurin inhibitors, steroids, etc. And they were tried with a new investigational drug, a combination monoclonal antibody. I think it's made by Novartis that binds to IL-1 beta and IL-18, two mediators of systemic JIA, Still's disease, also big players in what's going on in macrophage activation syndrome. It turns out that the use of this MAS 825 antibody was very successful in both the acute control of MAS, but also that there were no recurrences, I think, in the year that those patients were followed. So this really speaks to what is your thought process, what is your approach to someone who develops macrophage activation syndrome. The vast majority of those for a rheumatologist is going to be patients with Still's disease, whether it's kids or adults. But it can happen in lupus, it can happen in infection, it can happen in malignancies and whatnot. Again, the management is steroids, and then the old management was choosing between etoposide or cyclosporin, a calcineurin inhibitor. The new approaches that are maybe safer, and these people are really sick, by the way, is the emapalumab, that's the gamma interferon monoclonal antibody approved for HLH. It's called Gamifant, but it's probably going to get approved for MAS due to Still's disease. I would hope in the next year or so. But there's good, Fabrizio Di Benedetti in Italy has done, cohort, I think 16 patients now, where it's had really great effects, and hopefully that'll be enough to get it approved. I've talked about JAK inhibitor use and when you have nothing else to use, that might be something to consider. Again, it's not approved for use in MAS, but you can see that we're beyond the older ways of managing these patients, which wasn't always successful. We talked last week about RA patients with disease activity having a higher risk of renal insufficiency without necessarily attributing it to RA. It could be due to RA, could be the drugs we use to treat problematic RA. There was a report this week of retention rates on biologic DMARDs, and that included TNF inhibitors, IL-6 inhibitors, and abatacept in 425 RA patients followed for 3 years, and looked at their retention rates based on their estimated GFR, showing that basically there was almost no change when you use biologic DMARDs that affected it. Now, there was a little change with the TNF inhibitors. The retention rates went from 45% down to 34%. Went up a little bit with IL-6, 47% went up to 71%, and really, 50% to 33%, but overall, there was no change. There's a lot of spread here, and the confidence intervals are wide, but it would basically says that using aggressive therapies probably isn't the reason why patients' GFR changes, and that it probably is safe to use biologic therapies in patients with RA and not have to worry about necessarily their renal function. I put in the citation about RA and activity as well in these notes. I look at a lot of marketing data sometimes and stuff that comes from the pharma companies and agencies that try to serve the educational needs of pharma. And one marketing piece said that based on their research, this is not a paper, not a journal article, but this is marketing research, that the global rheumatoid arthritis market was estimated to be worth almost $23 billion in 2021. And it's said to go up around, I think the number was 4 or 5% annually, and is estimated to reach $33 billion by 2030. Why am I telling you these numbers? It's big money. You're a big cog in this big wheel. So many rheumatologists think, I'm just a lowly rheumatologist. We only have 5,000 rheumatologists in the United States. We're not too important. They certainly don't pay us like we're important. And let me tell you, when you control, in the rheumatoid arthritis industry at, $30 billion a year, or the use of the drug market for rheumatology is probably a $60-70 billion market. And who influences that more than the rheumatologist? Not many. You're very important. So you need to know your worth when it comes to what you say goes when it comes to managing these patients and the use of better, newer therapies, or I should say potentially better and newer, but certainly more expensive therapies. I found an interesting cohort study about the associations between GIrd and outcomes in patients with systemic sclerosis. So while 96% of patients, 500 patients roughly, had evidence of GIrd, turns out, and there was always been this issue about whether GIrd influences the onset of ILD. And I wonder how that happens. Is that through some kind of reflux and aspiration? That is this then the inciting event? Again, the mechanics haven't really been worked out, but it's always been hinted, right? So this research says that GIrd did not influence the diagnosis of ILD in scleroderma patients or its severity. However, GIrd treatment with either PPIs or H2 blockers was associated with improved survival in scleroderma patients. That's like a backdoor answer to the problem. So this is a curious area. I don't think we have all the information, but this one cohort analysis says maybe not. Something for you to consider. Let's look at myositis and ILD. We do know that myositis patients, when we're talking about PMDM, who get ILD, they, like RA, like lupus, have a much higher mortality rate, much higher complication rate, much more morbidity with pneumonias, etc. A study of 190 myositis patients versus myositis mimics, over 400, showed that if you look to predict ILD, doing myositis specific antibody profiles increases, or having one of those like Jo-1, for instance, increases the risk of ILD sixfold. Having a Rho52 antibody increases the ILD risk eightfold. Having dual positivity with both of those increases the risk of ILD 20-fold. Wow. I got to tell you, I've never been a big believer in doing myositis specific autoantibody testing because it didn't really change my thinking. Some of this data does. So maybe it changes yours, maybe it doesn't. Two more reports. I like the report this week from Dr. McCoy talking about Sjogren's disease, specifically seronegative Sjogren's patients. Her report in Room Now, or actually published somewhere else, we wrote about it, was that 1/3 of Sjogren's patients often do not have an antibody positivity, either with Rho, SSA, or La. We like to lean more on SSA. And one of her questions is, how do you diagnose that with reliability without doing a labial biopsy and a focus score greater than 4 or whatever? So she did an autoantibody panel looking at IgG antibodies, looking at SSA negative Sjogren's patients, Sika controls without autoimmunity, and then patients who had autoimmune features. There's about 200 patients overall. And she found that antibodies to DT-D2, or the D-aminoacyl tRNA deacylase, DT, this is new to me, so that's why I'm stumbling, DT-D2 antibodies were more prevalent, significantly more prevalent in autoantibody negative Sjogren's disease patients, meeting criteria otherwise, compared to the both control groups at a fairly high significance level. So that, and there was another autoantibody profile. Anyway, I like this research because I think sometimes we think we're on thin ice when diagnosing Sjogren's syndrome, and there are many of you out there who think that maybe we're not diagnosing enough Sjogren's syndrome. I'm not so quite convinced, but I'll listen to people who are, and people who are the experts on this, and hopefully make up my own mind. But I like the idea that research is being done on this. The last piece I want to talk about is the risk of inflammatory arthritis, IERA or JIA, based on prior exposure to antibiotics. I have written about this 4 times in the last, I think, 2 or 3 years, with 2 good reports showing antibiotic use portends the risk of RA, or inflammatory arthritis, and 2 other reports showing that it increases the risk of JIA. Oh my. Well, I got another one, right? And this one is a study of almost 30,000 new onset inflammatory arthritis, half of them being RA and the others being PSA, SPA, and they were compared to basically 285,000 population controls. And they showed that prior antibiotic prescribing was found in 42% of the inflammatory arthritis patients compared to only 31% in the background population. Basically, this suggests almost about a 50% higher risk when amongst the patients who ultimately developed RA, PSA, or SPA. And it was like 48%, 67%, and 52%. What's the deal there? And I guess the real question is, does that just mean that people get antibiotics or sicker people are going to develop other things downstream? Autoimmune disease, inflammatory arthritis, cancer, they're more likely to get hit by a bus. It's really maybe a non-specific marker, or is there something to it? Does chronic antibiotic therapy or repeated, and some of those reports I mentioned before, not this one, did say that more exposure was associated with higher risk. So does antibiotic exposure change microbiome? And does microbiome changes in a certain host lead to the development of preclinical disease and then clinical disease with external factors like diet, smog, smoking, God knows what else? Again, these are interesting ways of considering how we get to what we've got. What we've got are people with inflammatory arthritis. How do we get there? If we really want to affect that outcome, we're not going to do it with a brand new expensive IL-29 inhibitor. Sorry, I like having more options. If we really want to affect the outcome, we need to be in the prevention business. Who's going to be more inclined to investigate or affect prevention than the rheumatologist? I don't know. So yeah, it's your job. It's your concern. I'm giving you the information. You got to run with it. Start running, people. We'll talk next week. Bye-bye.